So, with no further ado, I'm going to continue to encourage you to introduce yourselves in the chat box, but I'm going to give a very, just very brief introduction of our three speakers today. We're really excited. I'm really excited about this conversation. And then I'm going to pose the question that sort of came from your registration and that we've crafted for today to open today's conversation. And then I'm going to ask Sharon, then Anila, and then Margo to answer it. So first of all, I'll just give a high-level introduction. Sharon Davis-Murdoch is coming to us from Nova Scotia, from the East Coast, and she's a founding member of the Health Association of African Canadians. And as such, Sharon has led the development of health policy that is culturally specific and has recently worked on COVID-19 interventions that have addressed the needs of African Canadians in Nova Scotia throughout the pandemic. We also have Anila Lee Yuen, who's the President and Chief Executive Officer of the Centre for Newcomers. And that center is a nonprofit charitable organization that provides Calgary immigrants and economically disadvantaged individuals with a solid foothold in Canada. And during the Alberta's first COVID-19 lockdown, Anila oversaw an ethnic food hamper program for marginalized communities, providing almost 6,500 clients with culturally comforting food. And so we're looking forward to hearing from Anila. And then finally, Dr. Margo Greenwood. She's the academic lead of the National Collaborating Centre for Indigenous Health, as I said, one of our sister National Collaborating Centres. But she's also an Indigenous scholar of Cree ancestry with years of experience and wisdom focused on the health and well-being of Indigenous children, families, and communities. Margo, as those of you who know her and love her, wears many hats, and she's also the Vice President of Indigenous Health for the Northern Health Authority in British Columbia, and she's also a full professor in both the First Nations Studies and Education programs at the University of Northern British Columbia. So we welcome Margo here with us today. So Sharon, I'm going to pose our question to you first, then Anila, as I said, and then to Margo. And I'm going to ask you to situate yourself. You can expand on that introduction that I provided. But our guiding questions for our conversation today are, and they're kind of two sides of a coin, how can communities ensure that their voice is heard and specific needs are met during a public health crisis such as COVID-19? And then the other side of that question is, how can public health ensure that they're engaging with community to develop effective and equitable responses, interventions, programs, actions? So how can communities ensure their voice is heard? And then how can public health actually engage to make sure that that voice is lifted? So Sharon, over to you.
Okay, good morning, everyone. Delighted to be here. Sending greetings from sunny Nova Scotia. I would like to also start with a land acknowledgement. These are the words of Robert Wright, who is a colleague of mine. The Health Association of African Canadians is a member of the Decade of People of African Descent Coalition in Nova Scotia. And he signs many things or finishes many emails with this acknowledgement. So I'm going to give it. I would like to acknowledge that we are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship. I would also like to acknowledge that racism is North America's original sin, that is at the root of all current social inequities. Acts of reconciliation and reparations, both symbolic and substantial, are critical to our collective emancipation and the ability to live peacefully and sustainably on this land. So I would begin with that and also say that I am a founding member and the co-president of the Health Association of African Canadians. I've had many, many, many years of policy experience as I was with the Department of Health and Wellness for well over 20 years and started my career in policy affiliated with government, being paid by the province of Nova Scotia, let's put it that way. So what I would like to do is, rather than answer those questions, sort of specifically, I'd like to tell a story, the story of our work, which I think gets to answer your question, but puts it in more context. So I will try to stick to my 5 minutes, but here goes. So from the beginning of COVID-19, the Health Association of African Canadians, our acronym is HAWK, stepped up to fill the void, and there was a void. As you will know on this Zoom meeting, COVID-19, the pandemic, hit the world, and almost immediately we started to hear about the disproportionate effect of on people, racialized people. However, where people of African descent were concerned, social media was full of misinformation, information that said that Black people were immune to COVID-19 and that if you were not European, it wasn't going to affect you. We were absolutely terrified at HAWK with this kind of information going around, and people basically just continuing to circulate misinformation, talking to each other. And as usual, and has been the case, unfortunately, the province of Nova Scotia, the government itself, public health included, did not have information that was culturally specific to Black people, so that the only information that was directed to us was misinformation that was going round and round. So what we did almost immediately, we stepped up to fill the void, as we do, as we have done since our establishment in 2000. We started with culturally specific messaging, and the method we used was with a town hall. We invited all of our members and all of our networks and asked that they invite others. And we had hundreds, well, maybe I'm exaggerating, it was less than 100, but a lot of people online. And we then began to break down the information that we knew was correct. We also reached out, as we have done from that time since, to public health. And in Nova Scotia, you may know that the Deputy Medical Officer of Health is Dr. Gaynor Watson-Creed. She is a friend to us, and we are a friend to her. So we reached out to her and asked that she be on the town hall to give us the facts, but also to participate in a culturally specific, and we use the language of cultural competence quite proudly, culturally competent and culturally specific information about COVID-19 as it relates to us. We also had HAWK doctors, including a psychiatrist who was able to talk about the psychological impact of COVID-19. At that point, we did not have a provincial state of emergency. It soon became the case that we had that state of emergency, and we continued to have town halls. In fact, we are continuing to have town halls. What do we know about our populations in Nova Scotia? As COVID-19 hit us, so did the pandemic of anti-Black racism, and the Black Lives Matter movement came into full force in the same period of time. We knew that our people were going to be disproportionately and inequitably affected by COVID-19. We knew that because when we're talking about social determinants of health, housing, income, frontline work of our people, poverty that has existed since we came to Nova Scotia in the 1600s, pre-existing conditions of our people, chronic disease, comorbidities, and the stress of everyday racism, of systemic, of internalized, of structural racism affecting us and making us vulnerable across age groups. In Nova Scotia, as is the case in the rest of Canada, we also have no health data with race, ethnicity, and language identifiers, something that I personally and HOC has been working for since 2000. We have lobbied, we have questioned, we have met, we have cajoled, we have supported the need for this data. We continue to do so. We have hopeful signs, but we don't have the data yet. With no data, we cannot show in an evidence-based way the kinds of ways in which we are disproportionately affected by diseases, the burden of disease, ill health, and social inequities. There is the mental strain of that racism, the trauma of seeing our people mistreated on television and in real life, every day, systemically and structurally. However, the pandemic has shone a light on these. So it comes with a new opportunity, perhaps, and new approaches, we hope. Our first town hall was March 13th. We also had the formation of the Association of Black Social Workers and the HOC COVID-19 Response and Impact Team. Public Health Liaison is part of this work. That team began in March of 2020 and continues and will continue until the last vaccinations are given and we are back to a new normal. We are in place, we are working every day, all the time. In Nova Scotia, we were not heard in the mainstream. Public health talked to us about issues in Black communities, particularly where there was concern that there would be a spread of COVID due to all of those factors that I mentioned above, and certainly people traveling back to Nova Scotia from Ontario was one way in which this spread began. We were very concerned about that, and people on the ground that are part of our initiative were concerned as well. And in fact, young Black people in the what we call the Preston Township, which is made up of North Preston, East Preston, and Cherry Brook, they reached out to public health, worked with public health, and were able to stamp out COVID-19 spread in the Preston Township within weeks, within very short time, because of the concentrated effort and the culturally specific outreach. And with our initiative in place, we connected the dots. More town halls have followed. We continue to keep our people informed about the virus, about the kinds of things that we need to do. We also we have provided things such as food boxes when people were on lockdown, health supports, things like blood pressure monitoring machines, diabetic socks, you name it. We also provided things like garden supplies, craft supplies to keep people healthy, mentally healthy, active, and our town halls talk about mental health and coping with the realities of our lived experience, which, as I have said before, means dealing with racism in all its forms. We recognize that with the coming of vaccines would be, again, a exclusion or at least a suggestion that all Nova Scotians are the same and that one size fits all, and there would be nothing culturally specific to our people. We were concerned about that, and we reached out. We talked to the press. Actually, the press was trying to find us because of what they were hearing about in the US, in the UK, and across the African diaspora, where our people were dying in high numbers because of COVID-19. They wanted to know what was going on in Nova Scotia. They reached out to us. We talked to them. We had continued these town halls. And so finally someone said, oh, you're having town halls. We said, yes, we've had them for a year. And indeed, we are concerned that vaccine mistrust, not hesitancy, mistrust is going to be a factor. Why wouldn't it be? Our people haven't trusted the health system because the health system has not responded to our needs in culturally specific ways and culturally competent ways from forever. And so our language, our message to through the press was, we need to address vaccine mistrust, as well as prioritizing our populations who are disproportionately affected and who will continue to be. And so that's where we are now. Government is very keen on working with us now. We are working with them as a result of, I think, all of the work that I've described, and public health is part and parcel of that. And thanks to Dr. Gaynor Watson-Creed, who connected this and made the point that the government of Nova Scotia needs to work with African Nova Scotian leaders. We are here and we are planning our first culturally specific vaccine clinics in communities of people of African descent. So having said that, I thank you for your kind attention, and hopefully if I haven't answered those questions, I'll have a chance to do so. Thank you.
Well, I think you answered those questions superbly, and just to acknowledge Dr. Gaynor Watson-Creed, she is also our friend as well, and what a friend indeed. And she's the co-chair of the National Collaborating Center for Determinants of Health Advisory Board. And but Sharon, wow, that is addressing those basic needs, but also very, very effective advocacy at the highest level. So in 5 minutes, that was incredible, that story. Thank you for telling that story. Anila, I'm going to hand it over to you, and you go ahead.
Thank you so much. My name is Anila Umar Lee Yuen. I am the President and Chief Executive Officer at the Center for Newcomers. I'm really grateful to be here today. I'd like to acknowledge that where I am, where I was born and raised, is the traditional lands of the Blackfoot Confederacy, known as Mohkinstsis or Calgary, the Elbow. We are in Treaty 7, and Treaty 7 comprises the Blackfoot Confederacy, which is the Kainai, the Piikani, and the Siksika nations. We also have with us are the Stoney Nakoda nations, which include the Bearspaw, Wesley, and Morley First Nations. And closest in proximity to us, there's actually an invisible line, I like to say, because I don't think it's really a real line, is our Tsuut'ina Nation. Calgary is also home to Métis Region number 3. And of course, all of us, settlers and newcomers and everyone else that choose to call Calgary our home. In terms of you know, the work that I get to be privileged to be a part of, I am not only the CEO at the Center for Newcomers. We are a large-scale not-for-profit organization that works with newcomers in Calgary. We see about 15,000 newcomers per year. We also are I'm also chairing the Calgary Northeast Newcomer Collaborative, which is a collaborative of 17 organizations that are working together. Some of us are newcomer organizations that are funded by Immigration, Refugee, Citizenship Canada at the federal level. And some of us are other social services agencies that are funded through other groups and are much more broad-based, not only serving newcomer or racialized communities. So this was really important. And as we talk about how can communities ensure their voices are heard and specific needs are met during a public health crisis, it's to start ahead of time, right? It's much more difficult when the crisis occurs and then we're trying to figure out what we're going to do. So for us, we felt like we were already ahead of the curve because we had this Northeast Collaborative. And for those of you that are not familiar with Calgary, most newcomers and racialized communities live on the east side of Calgary. It's just demographically how the city has always just evolved. And so we'll see about 80 to 90% of racialized communities and newcomer populations. So those people that have been in Calgary or in Canada less than 5 years, permanent residents, temporary foreign workers, undocumented, or refugee claimants are mostly living on the east side. And a lot of that has to do with housing and, proximity to work as an essential services and different things like that. And so our work was really in terms of outreach and trying to incorporate or to reach out to as many newcomers specifically. We were targeting that 5 years and less to be able to know that they have different services that are available to them for free. So when COVID hit, we were able to use that backbone to be able to advocate very quickly. So what literally happened was we got together as a core group of the 17. So there was about 4 organizations that got together and we said, okay, we're seeing the numbers rise. We're going into second wave. So this is after the first wave. So we're going into a second wave, which is about November-ish. What are we going to do? Because the numbers are rising and the hot zones, as our Alberta Health Services had told us, were actually in Northeast Calgary. So what are we going to do? And so we got together, we figured out a response, which is if you go to our centerfornewcomers.ca/eastzone, you can see this entire collaborative response. I drew it out. I literally drew it out, took a picture of it. And next thing I know, because we started calling out, I've got the mayor of Calgary calling me saying, Anila, get me what you have, because we really need to do something. And the numbers are rising like exponentially. So I said, all I have is this like picture of this thing I drew in terms of, how we want to move forward. He said, send it to me. And then he said, give me how much it's going to cost. So then we get together, we start frantically calling people saying, how do we put this together based on what we're already doing? We came up with a number, right? We said we need $1.6 million for 4 months to be able to do this effectively. From that, he called the premier said done. And within a day, we had $1.6 million. And the backbone of all of this is that we have a one-stop shop utilizing community members that are in the ethnocultural, racialized, and newcomer communities that are already trusted, that we're able to hire as cultural brokers. They answer a crisis line. And so anyone that has any issues related to COVID can call in any language, of course, in English as well. And they can say, this is what my need is. And then we have a whole network, which we've been using called the Gateway System, which is a partner portal where we get notifications saying food security, it goes to Center for Newcomers. Income support, it goes to so-and-so. Employment, it goes to so-and-so. Whatever those needs are, and then those organizations do the triage and work with. So we've got over 150 organizations, and every morning we meet at 8 a.m. with the core organizations, with all 3 levels of government, with Alberta Health Services, and with our crisis management team from the city of Calgary. And we work through any specific issues that are happening. So we're in real time able to deal with the trends. So, I know I've used my 5 minutes, but that's really where we are. That's what we're doing. And we're really looking to be able to increase that in terms of a more stabilized response. So even after COVID is over, how do racialized communities, how do newcomer communities, how do communities that need other language supports get a one-stop access to be able to then work with this collaborative? And so we have a lot of data already that we've collected since December 17th that we started. And that you can go to our local immigration partnership website and you can see all of the different presentations that we've done that give you everything from data to incidental information to demographics to everything else.
Thank you so much, Anila. And Claire Ogorman just put in the chat box here, and I think that applies to Sharon's story as well as your story, is having that backbone structure, whether it's town halls or 8 o'clock in the morning meetings, and then those trusted and previously, I think is your point, developed relationships amongst people and with organizations is absolutely critical. And I think that can-do attitude, right? There's an issue here. We together can work on this. We actually together can make a difference. So thank you for sharing that very complimentary story to Sharon's. And I just want to mention that Anila was recently named one of Canada's top 25 women of influence, and I think we can see why. So thanks, Anila, for sharing that. Okay, Margo, over to you, and just answering those same questions. And I think you've got some ideas about what you want to share there, and we're looking forward to that. Margo.
Thanks, Claire. Margo Greenwood, Nita Kitson, I am Nihio from Treaty 6 in what is now known as Central Alberta. So close to you, Anila, my traditional territory, the homeland of my people. I am coming to you today from the unceded lands of the Silks people, and am grateful and acknowledge them for the opportunity to live, work, and play in their territories. So miigwech to them. I have to say, I'm so impressed by the speakers and their stories. It's incredibly exciting and incredibly good work. So I don't have those rich stories. I have my own story, I guess. So when Claire asked me to speak on this panel and to talk about partnerships and how people get their voices heard in times of pandemic, I really had to step back and reflect about a number of different roles that I play. But one of the things that occurred to me is that these kinds of partnerships, these necessary, I think, partnerships and engagement and conversations happen at multiple levels. I think they happen at local levels. I think they happen at regional and provincial levels. And I think they happen at national levels. And I've had the opportunity to be in a number of those arenas. So a couple of the examples that I want to share with you are across those boundaries. I think I'll start with a local example, and this draws upon my role as the Vice President of Indigenous Health for the Northern Health Authority. And one of the things that we do, and I was really grateful to hear earlier, and this phrase always sticks in my mind, and I think both of you said it, COVID, the great revealer. It reveals all the inequities for all of us, and the challenges that we face in this work. And in saying that, even though we're living in these completely extraordinary realities, I think they are extraordinary realities of opportunity for change and transformation. And that's what I hear when I listen to your stories. I hear these opportunities for transformation and change. And I hear how community walks that reality and has those solutions. And I lift my hands up to those folks. In my little role that I play, one of the things that we really wanted to do well is, as all of you know, we had the mass immunization clinics happening in Northern British Columbia, and they were in urban settings, but we knew that many Indigenous people and non-Indigenous people would be using those clinics. And I really appreciate your words around cultural or vaccine mistrust. because the history on the health system hasn't been always friendly to a lot of people. And so there's been a lot of mistrust around that. And so in thinking about the mass immunizations clinics, we were thinking about how are we going to ensure that these clinics are a culturally safe experience and a culturally safe environment for Indigenous peoples that walk in those doors, First Nations, Inuit, Métis. And so we have a number of partners that we work with up in the local, in our health authority. We work with the First Nations Health Authority. We work with the Métis Nation, British Columbia. We work with the friendship centers across the north. And so what it was a matter of pulling those partners together and say, how are we going to do this work together? So two amazing things, I think, came out of those conversations. One was the development of a plan. And I believe the link will be in the chat box. I've sent a lot of links to some of the, a lot of the documents that we've created and done. And the second thing is that people were actually engaged in the service delivery. So First Nations, Métis and Inuit peoples and peoples from the Friendship Center were actually engaged in service delivery. So let me paint the picture for you. So when you go, and I'm speaking from Northern Health and my experience there, when you come to the clinic, there's signs that tell you where to go. We made sure that those signs were in the traditional native language, as well as English, as well as Métis, Cree-Métis. So Tansei would have been there. So when an elder and seniors, and we were really thinking about the elders and seniors that we were serving. So when they would arrive at the clinic, they would see something familiar, especially if it was their language. And of course, we use the language of the traditional territory in which the clinic is situated. Then there was really good signage inside. And then what we did was we created a position called a greeter. And so people would be there that would distinguish themselves as First Nations or Métis, or from the Friendship Center. People had name badges and those sorts of things. So if an elder was a little bit unsure and maybe their daughter or granddaughter had to drop them off and so they were by themselves, a greeter would greet them right away and take them through the process of registering and signing in. If they had come alone and they were a little bit nervous, though, we had the next position we created was called a wayfinder. So when they actually went to get their needle, a wayfinder would walk with them, so they were never alone. And as they got their needle in their arm. From there, they would then move to where you have to sit for 15 minutes. So this whole process is about 25 to 30 minutes. Then they sit for 15 minutes before, just to make sure that everything's okay and they're fine. In that area, we had another position called a host. So that would be a First Nations, Inuit, Métis person who would be hosting and making sure we actually offered our folks juice boxes and bottles of water in a COVID environment. We had to be very, very careful about that, but ensured that they were comfortable in that. Some of the feedback we've got is some of the elders so enjoyed that they would start visiting. It was like a visiting place because they hadn't seen their friends for so long. And this was actually a really positive thing that they were getting this vaccination, and that we tried to make the environment as friendly, as welcoming, and as familiar as possible. Oftentimes when you haven't been to a place, but you see somebody or you see a painting or you see a sign, you know that someone's walked there before you. So it makes it a safer place for you. So we wanted to create that kind of environment. That was a partnership between local community partners that were also provincial in nature partnerships, and that we could actually design something, we could vision it, and we could actually implement it and see that it worked. And of course, there's adjustments and all those sorts of things. And that we could actually do that work together, that it was right in the delivery of services as well. this is really important, I think, that people see their community members and their people in those places. That starts to combat that vaccine mistrust. We have a long ways to go in that area for many people. And I think small things like this can make a huge difference. The link to that document should be up in the chat box, I'm hoping. Claire, you'll have to tell me how I'm doing for time. I have another example if you want to hear about that one. Have I got time, or would you like me to stop there?
Yeah, sure. Maybe one more example.
Okay.
Margo, that was an excellent story. And then where I'm going to go is I'm going to ask Anila and Sharon maybe just to respond to some of the things that you've said. So go ahead, Margo.
Okay. So the quick story is around, we all know about the national racism meetings, I think, that have been taking place, that took place late last year. And then again in January of this year, really around Indigenous specific racism that occurred within the healthcare system. That was huge and still a huge and ongoing issue, particularly in the province of British Columbia, where we just had the Mary Ellen Turpel-Lafond report that came out in late November and December. You know, really having a really good in-depth look at the BC healthcare system and some of the things that she found there. So truly one that I think we all knew, but we certainly have the evidence that supports that now and more. One of the things that in preparation for the racism meeting, but more importantly, with respect to COVID-19, we were hearing from a lot of people around the stigma that went with having COVID-19 and the discriminatory behaviors that people were experiencing. And it wasn't just Indigenous people, it was many people. You know, if people found out that you maybe had COVID-19 or were self-isolating for that, people kind of, you know, had that little, oh, I should stay away from you kind of feeling. And I know a lot of people were feeling that, and we knew that that was a challenge. I was hearing that on many national meetings that I was on. So what we did was we developed a, well, first of all, we did a rapid review around stigma and COVID-19 and Indigenous peoples. And that was informed. We had some medical students who did that for us. It was an amazing report. And it's on our website. These links will also be in the chat for you as well. But one of the things that we did around that was to create a stigma video. And that was, you know, this work was done in partnership with the Regional Health Authority and the National Collaborating Center for Indigenous Health. So it really started as a regional process. We knew about stigma and discrimination and what was happening for Indigenous people around that. And so we did a report to gather the evidence. But of course, as was pointed out earlier, there's no disaggregated data that you can go to. So it's really hard when you're trying to do this kind of work without that. And then one of the things we knew we needed to get the message out, and not everybody's going to sit and read a rapid review. Let's face it, you know, that's pretty academic. I'm sure our public health folks would be reading those though. But what we wanted to do was to get that message out to much broader. So we created a video that is around stigma and COVID-19. I think it's a really powerful video. We had community engaged in that. What's exciting, I think, about this piece, and not that I wish we never had to do this kind of work, but we do. We are in that reality. But we could take something that we built at a regional level within a partnership between a health authority and a local university and the National Collaborating Center, and take that work right straight to a national platform. So when you have those local voices coming forward saying, this is the problem, Margo, this is a problem. How do we get that out? This is a really good example of taking that local problem. We built some things around it and we took it right onto the national platform. So I think that's kind of, you know, exciting in terms of it's locally significant, but certainly is applicable across the country. So I'll stop there, Claire.
That's an
Thanks.
excellent example, Margo. And one of the questions that I just saw in the chat box, and I'm going to ask Sharon and Anila to kind of respond to what you said, Margo, is, you know, never underestimate what is actually possible, right? Right from that community voice. This is the problem, Margo, having those relationships with you and taking it all the way very quickly, actually, to a national platform. It's an excellent video, excellent video. That I think is in the chat box there, and people are responding to it.